I was on the committee, the select committee that looked at Lord Joffrey's second bill, which was the assisted dying for the terminally ill bill. And this was the long title of the bill, and I've put in blue the words that we as a select committee had concerns about. The problem is, first of all, how do you assess capacity? How do you assess that fluctuation in mood and approach that sometimes you're in despair and other times you're out the other side? And I'll go on and tell you a little bit about some patients in a short while. There are real difficulties around that, and the fact that your perception of what lies ahead is often influenced by things that almost always that you've seen before, things you're frightened of, the drugs that you're on, steroids, morphine, all those drugs can alter the way that you think about things and feel about the world around. And if people around you make you feel that you're a nuisance, then it's very easy to think that you shouldn't be there. The problem with suffering unbearably is that as a doctor, I personally want pressure to be on doctors to relieve suffering, not to say, you're suffering unbearably, therefore you're eligible, therefore we leave you suffering, because if we start to relieve your suffering, you're no longer eligible for assisted suicide, which is what you're asking for. So there's a real problem in that wording. And actually, I do feel very strongly that clinicians should redouble their efforts if they're not improving people's quality of life and helping them adapt to their situation rather than stopping managing them. Terminal illness, it's really difficult to know when somebody's terminally ill. The committee heard from the College of Pathologists that about 20% of postmortems show that the person didn't die of what was on the death certificate. That's pretty horrendous. And of those, a significant number were not dying at all of an illness that would have been a terminal illness. They actually died of something that would have been treatable, but it had been misdiagnosed. So there are real problems around that, and we can't predict prognosis. I know that even if I sit down and think somebody is in the last 48 hours of life, and I look at them and I think they are dying, dying, dying in front of my eyes irreversibly, 3% of the time I will be wrong. And I've been looking after patients, thousands and thousands and thousands of people who are dying, and I can't get it right, even at that stage. And the further away we get from when they die, the more wrong I know that I've been. In both directions, sadly, sometimes thinking somebody will be fine for a few weeks and they die straight away, something happens. But also the other way around, of sitting down with the family saying, I think they should stay overnight or whatever, or warn them that somebody is dying, and next morning the patient's sitting up in bed having breakfast. And we just can't predict. I have a concern about medical assistance, and I think some of the Dr. Martin stuff and the ignorance that that's revealed and the arrogance in attitude perhaps underlines the fact that it's really dangerous to let doctors have a license to decide when somebody lives or dies. And if you think about a considered and persistent request, well, how considered does it have to be and how persistent does it have to be, and what's the cooling off period? And I'll come on to that as well. Our select committee felt that it's important to differentiate between these three things: euthanasia, physician-assisted suicide, and assisted suicide. There is this term assisted dying, which I really worry about because it's a kind of sanitized way of covering this lot, because it's not really saying what it's doing, and it's almost like, well, if you're on the top of the cliff, well, we'll just push you over. But we don't know how near the cliff edge you are because we can't predict prognosis, but never mind, we'll say that because you're ill, we'll push you over. And there is a problem with that too, in terms of what the law does then to protect people from coercion, from pressure, who have disability and who have illness. Now, the problem with all the debate and the discussion is that the debate is really conducted by people who are well. And it's very much around what if, and I wouldn't want, and I'm looking at my relative, and so on. But actually, when people are ill, it's not theory, reality's changed. And they have to adapt to reality. And that's a really, really difficult process. And they are making decisions. And the more ill they are in general, the more vulnerable they are to the influences and pressures and picking up signals from people around, both healthcare professionals and family. And when people are very ill, in whatever situation, by and large, they pick up a whole lot of little signals that in life they didn't pick up. It's almost as if they become hypersensitive emotionally. So the grunt, I've just made you a cup of tea. Do you really want another one? Gives, the message that you're being a bit of a burden. Do you really want me to go upstairs again? Could you wait? Or do you want me to go down and get your handbag? And said with that sort of sinking feeling that gives the message you're a burden. So there are influences that may be external, but there's also that internal influence of, I don't want to be a burden on my family. I don't want them to remember me badly, and a sort of internal coercion that perhaps I would be better off dead. And those of you who are parents in the room, I'm sure identify with the thought that actually there are times when you would do anything for your children. There are times when you would lay down your life for your children. And one has seen that throughout the ages and throughout history. So how do we actually make decisions, and how do we make decisions generally in life? Well, it's based on our experience. That's the big thing. Seeing is believing. If you have had an experience 30 years ago of somebody dying badly, that is emblazoned on your memory. You do not erase that. If it was 40 years ago, 50 years ago, that is what you remember. What you've seen and you've experienced, that's reality. The fact that science and medicine and care provision has moved on, the fact that we now have the whole of Wales covered with palliative care services, that we have advice available 24/7, you may not know that. In fact, I wouldn't expect you to, because when I came and started the services in '87, I was the only consultant in the whole of Wales. And there was nothing else. So I've seen it go from being nothing to where we are today. And most people's experience of dying isn't in the last few months since we've got 24/7 working everywhere. It's been years and years ago. So it's our memories, it's our current situation. It's also the information that we get. And it's not the formal information, the information leaflet that you get given. It's the face of the doctor when you walk into that consultation. The looking down, the looking a bit gloomy, putting the pen down, the sigh, you pick all that up. You pick up bad news, bad news, bad news, negative, negative, negative. The nurse who whizzes past the end of the bed doesn't stop. The slightly sympathetic look from somebody as they go past, those are the things that you pick up. Those reactions of round and of feelings around. And people are frightened. They're frightened that the future will be worse than today. They're frightened that pain will either be there or will come back if they've had pain. They're frightened of losing their dignity. They're particularly losing their mind. Frightened of so-called losing control because the disease has taken control away from them. They no longer can do the things that they would want to do because disease is taking it away all the time. A loss of sense of autonomy and frightened of being a burden. Now, yesterday I was fortunate enough to meet Chris Woodhead at a motor neurone disease reception in Parliament, and he was speaking, and as some of you know, he lives in North Wales. And he was saying how his situation now, being in a wheelchair, is something that when he was well, he thought that he could never handle. But he finds that life is incredibly rich. He is now noticing things with a poignancy that he never noticed before. The flowers coming up in the garden, the roses, the spring blooms, had a vividness for him that he'd just never noticed previously and never really appreciated. And it's as if his senses are now heightened.